Good afternoon, everybody. I don't know why they gave us the hard rock intro. That was a little weird, frankly, but this is going to be a fantastic panel. I am Sean Grimminger, President and CEO of the National Alliance of Healthcare Purchaser Coalitions. We are an organization that represents about 40 employer purchaser coalitions around the country. Together, all of our members represent about 45 million covered lives, so a significant portion of the commercial landscape. And I am going to ask my colleagues and our panel to introduce themselves briefly, and then we'll get into it.
Good afternoon. I'm Steve Sutherland. I'm the Senior Vice President of Information Systems at CERIS. We are a payment integrity company that works in the payer space.
Good afternoon. I'm Samta Shukla, Director of AI and Data Science at Blue Cross Blue Shield, Minnesota. I lead AI initiatives, executing on AI strategies, building teams ground up, coming up with the governance frameworks. I truly believe that generative AI has the potential to disrupt healthcare, and that's why I joined the organization.
Good afternoon. My name is Vikesh Tahiliani. I'm one of the physicians on HCA's Care Transformation and Innovation team. I work on innovations that will help our doctors and nurses out.
Thank you very much. So, I'd like to start with Samta. This is obviously AI is a dynamic space and a sort of what I'd say dynamic regulatory environment. Things are kind of quickly changing. And hoping you can give us all a grounding on what innovators are facing, what's the regulatory landscape for people who are starting to get into AI.
Yeah, so I guess I want to ground us in a little bit into the innovation that's happening right now. And if you think of the use of algorithms and predictive modeling, it's not new. It has been around since a few decades now. It's only because the generative AI has spurred that has made AI a true assistant to how we work now. And with that, there are lots of different challenges that come in terms of when it comes to regulation, such as ONC, HTI-1 regulation, and for us to comply to those, we want to make sure that we are equitable, we are interoperable, and we are transparent. So what we are doing in the organization right now is coming up with the responsible AI framework to ensure that that is the case, that all the solutions that we have are built within these guardrails. If you ask me the question that are we having methods to evaluate generative AI scales, generative AI solutions at scale for any use case in healthcare, the answer is obviously no, there is none. So what we are doing is building foundational work and understanding on a use case by use case basis, how can we come up with best practices around what we build? So coming up with model cards, coming up with risk matrices and readiness assessments on how a project looks like, what does it take? What does it take for it to be responsibly built? Having a lot of conversations with business partners. All of that will make sure that we are transparent. When it comes to interoperability, we still receive 80% of our documents through fax, right? So, and data systems cannot talk to each other. It's a big bottleneck because an average adjudicator sometimes spends looks at up to 22 screens to adjudicate one claim. And that becomes a major bottleneck. So we are trying to understand how can we reduce these bottlenecks to make sure that the data systems talk to each other and also the workflow is streamlined when it comes to interoperability.
Thank you very much, Samta. So, as I mentioned, I represent employers and purchasers in the healthcare space. And from our perspective, our healthcare system is inefficient and overpriced. And you may have seen the most recent Kaiser Family Foundation information shows that on average, employers are paying over $25,000 a year to provide family coverage. Depending on who you ask, maybe a third of healthcare spending is wasted. It strikes me that AI could be an incredibly powerful tool to drive better outcomes and patient experience while holding costs down. I'm also worried that it could have the opposite effect, right? That it could be a tool for certain players in the healthcare industry to find ways to increase their prices or increase utilization of low-value care. I'd like to hear all of your thoughts, as you'd like to answer, about how AI can be used in a way that's really focused on driving out waste and driving down overall costs for employers and purchasers and consumers, of course.
So I'll start off. Just thinking it from a clinical perspective, you go to medical school, you go to residency, you have years and years of training, and then you're not going to recall every single detail. So if you're faced with a patient and you have a diagnostic dilemma, I think AI could be really beneficial if you just put in some key facts about the patient, and if you've evaluated diagnoses that are just not panning out, patients not getting better. I think AI could definitely play a role in kind of helping the physician, not doing all the work, but just guiding them in the right direction so they minimize costs in the end. You're not ordering every test under the sun, trying to take care of the patient, which in the end helps the patient out as well.
Santa, I know we had spoken a bit about the incredible amount of administrative overhead in healthcare.
Yeah, so I have some figures tell that 25% of the healthcare spend is due to administrative workloads. And what we are doing right now to reduce that wastage you were talking about, Sean, we are trying to go on, we are trying to come up with strategies and algorithms to reduce the administrative burden or drive administrative efficiencies. And so it's like lots of different use cases that are in flux right now. So the claim adjudication use case that we have deployed gets to 47% more cases to be closed every single day because of the use of AI. We have, in the customer center work, we have member experience advocates receiving calls, and they have access to an AI-enabled chatbot that can help answer in real time, which is driving member satisfaction as well as reduction in workload for MEAs because they don't have to now pull up various documents where the knowledge is stored, and they can give more comprehensive and more compliant answers. It also helps them train faster. And then there is use cases around being able to come up with our own social determinants of health predictions. So lots of different use cases in the AI side, and cutting down on administrative workload is one of our major focus to reduce that wastage that you referred to.
Yeah, from my perspective, working on the payer and the payment integrity side, many use cases around claim adjudication, speeding up the process, automating the process, adding efficiencies to get the claims processed and paid in a much quicker fashion.
So, Steve, you're a AI-enabled vendor, right? I'm simplifying the work that you all do. I'd like to hear about sort of data use agreements and data sharing, because it's so critical to effective AI, but potentially problematic. So if a payer or provider is providing data to help the AI learn, what restrictions or requirements do they often put on a vendor? And then maybe broadly for everybody, frankly, do you actually trust the people on the other side of that transaction? Because once the data is out there, it's out there. And what do we do about that? Are there audit requirements? Is this an area that we need to be focused on?
Sure, yeah, great question. I think everybody understands how important security is, and data security and all of the things that you've heard going on in the space. So that is at the top of the priority list. As a vendor in this space, we don't own the data. We're working on behalf of payers, and we're working with providers. So we get the data in order to process the claims and to provide our reviews. So we are trusted with that data, but there is a lot of regulatory requirements, contractual requirements, data use agreements. All of that is very much in scope in our space to make sure that we are protecting the data and using it as it was meant to be used. And it flows down, right? So when we have one of our partners that we work with in the technology space, then those same requirements have to be held up all the way down through the line.
Thanks, Steve.
So,
Okay.
At HCA, I believe we have the largest data repository from a healthcare system in the world. So we burn a lot of calories on this. What we've learned is that if we give access to a certain portion of data and a vendor or somebody else tries to access more than that, we have audit systems in place that we can track. But once that data is released, it's honestly the honor system after that, because we really can't control what someone does with that data once it's in their hands. Now, we'd like to believe that everyone's honest and they're going to use it in the right way, but there's really no fine way to monitor that.
Yes, so you bring up an interesting point about honor system, and I would say that at Blue Cross Blue Shield Minnesota, we do have that in place right now, but we are trying to change that. So we have this very rigorous AI governance framework that we have in use since an year almost, and we are trying to come up with another rigorous framework for vendor vetting as well. And so what do I mean by that? As a first step, we assess all the vendor vulnerabilities related to the use of data and model, and an expert from the AI team would be sitting through and understanding, because we cannot build everything. We have to buy certain things from vendors, but we want to make sure that we are working with vendors who are trusted and compliant to how our practices are. The second thing is around the usage. So when I'm using their solution, what kind of autonomy does it give me? Is it deployed in the right environment? Is it secure? Can I point on that and say that? And then do I have access to their graphical user interface or an API? Like what kind of privileges I have on the implementation that is being done? And then when it comes to implementation, there is a very hairy concept of workflow, seamless workflow integration, right? Like I said, there are far too many screens for people who are doing adjudication on a common basis and auditing and compliance. And so we are trying to see if we can reduce some of those vendor black boxes and make the experience a little bit better for the people who are using these technologies day to day. So that's another thing we have a rubric for that we closely look through.
Thank you. So we have some questions coming in on the chat, and actually one by a clinician in the room had a series of questions that actually are very analogous to the ones we already discussed. So I'll start, I think, with, well, anyone can answer this question, but the question is, so physicians are now using AI scribes for documentation and to meet documentation standards for fully capturing the value of their work. How do payers feel about this? So maybe I would actually start, maybe if we could start with Vikesh to talk about how HCA is using AI, and are you using it in the way that's described by the clinician that we just discussed? Obviously, you're a clinician yourself, and then would love to hear from Santa about sort of how the feelings are among the carrier community, and Steve, if you have anything else you want to add there.
Yeah. So at HCA, we've partnered with Comure and Augmetics to help the physicians capture documentation. We've got 4 pilots in the ED. We're also working in the inpatient and outpatient space, and we're very close to getting into the urgent care space as well. And so the way the technology works is the doctor will walk into either the clinic or the hospital bed or the ED with a device, usually a phone. They'll push a record button and just have a normal conversation with the patient. When they're done with that conversation, they'll hit a stop button, and then within a matter of seconds or minutes, usually less than 2 minutes, a note is created that the physician just has to edit and sign. And so you can imagine early on, there were a couple of bumps in the road, but we've gotten to the point now where we're getting really high quality notes that what the physicians are telling us is, hey, my life is really busy, I'm going from room to room to room, and I may remember that the patient in bed 1 had chest pain while they were mowing their yard, but I don't remember some of the other details. And I can't read my chicken scratch that I scribble down on my scrubs or whatever. And so they're like, this AI actually helps me keep track of an accurate story, helps me realize what I said in the room would be the assessment and plan of that patient. And so there's a lot of cognitive burden that's reduced using these systems. Now, the technology is only going to get better and better, and I think this documentation piece is just one tiny piece of the larger puzzle that we're going to solve using AI.
So what's the experience for a health insurance carrier now that you're getting sort of basically, potentially claims that are based in part on notes that have been developed by AI?
So we are also using clinical summarization in a different way, but similar use case, right? So 2 of the areas that we are looking at exploring this functionality is one is when a clinician or a registered nurse is looking at the lengthy case notes or summary medical document or charts for any kind, so maybe auditing or for an outreach, or to just summarize the notes for adjudication. Can be any of these three use cases. We are leveraging large language model to get that summary. We have run evaluations, involved the clinicians to do the human in the loop evaluations, and have a POC in place right now. The POC shows that it has a capacity to reduce their work by 70%, so that they can focus on maybe engaging with the patient better when they're, for example, giving them a call because the summary is already taken care of. So this is a proof of concept that has been loved by the clinicians, and we are rolling it out for behavioral health line of business and behavioral health side of the business, and we are also considering implementing different versions for the medical areas.
So Steve, the second part of the clinician's question was, are they, in this case I think I mean carriers, going to get AI reviewers to audit aggressively now that the AI can do so? So we've got what I'm imagining is sort of a battle of the bots, right? Of claims coming in that are in part derived from notes, summarization from AI, come in, and then your job, in part, is to enable the ability to actually audit and review.
Right, and I was thinking of a similar use case that we have, that Samson was mentioning, a proof of concept where we are doing record summarization in a similar way. So you're right, some of those charts may have been partially created by AI, and then we're using AI to then summarize them and help adjudicate and help our nurse auditors. At the end of the day, though, at least for what we're doing, and I think the payers require us, or at least prefer us, we're always going to have an auditor sign off on that. An auditor is always
auditor.
Excuse me?
A human being auditor.
A human being auditor, yes, I'm sorry. So it's an AI-assisted review. It's not a fully automated review. And I don't see that changing anytime soon, where you would have complete automation of that. There may be some areas where, in certain situations, based on type of claim, those, lower complexity, that kind of thing. But always, we still have an auditor look at those.
So, actually, that went to a question that we had discussed earlier. What is the role of a human being with a human being brain in sort of keeping track of what the AI is doing, making sure that sort of final claims have actual human being eyes looking at them, or even if it's from the perspective of a provider or a plan. How do you make sure that there's sort of adequate or an appropriate human clinical or human interaction to make sure that things haven't gone off the rails?
So, when you start using technologies that use AI, there's a huge change management exercise, right? You have providers that have been practicing the same way for years, if not decades, and now you're asking them to leverage a tool that, in the grand scheme of things, is relatively new. So in our change management exercises in our education, we emphasize the fact that you are the human in the loop. None of this is official until you read it, edit it, and sign it. And that's ingrained in all of the education, and also after education, when they go live with the solution, we re-emphasize that almost on a monthly basis to make sure that it's not forgotten, that this is just a tool to help you. This is not going to do the work for you.
I have an interesting perspective on this. So yes, I am all for human in the loop. We are all for human in the loop as well. And I have an interesting example to share. So the chatbot that we designed to help the member experience advocates answer questions in real time from members, after we rolled it out, it was super popular. First 2 months, everybody was using it, lots of feedback, amazing. After that, it started happening that the more tenured people did not use it as much. And we started trying to understand why was that the case. Okay, so probably because they are like, oh, I can go to the SharePoint site and I actually know what the answer is. So they would just go off of their, the previously acquired notion or the understanding of problem that they have and give like an answer that they know from working for so many years, right, from their experience. And that was not very comprehensive or compliant. So we spoke with the leadership. We were like, we have to have proper incentive in place for everybody to use the chatbot, because we still want it to be human in the loop, but AI assisted. So it's not just humans, but AI assisted is actually important because AI can be comprehensive, compliant, and can reduce the overall work, even if you want to go off of your memory. So this is also actually something that ties to confirmation bias that is referred in the literature. And then the feedback piece, right? When a human uses a tool and then they tell whether the AI did a good job or not, and even like add comments on what it did not get right, that feedback is so important because when, this is alluding to another type of bias, which is automation bias. If you only have AI-generated recommendations without any human oversight, one may fall into the trap of automation bias because AI systems tend to exaggerate the inherent bias in the data. So we want to have the human oversight. So it's like both have to work very closely with each other. One cannot be working alone.
Right. All right, so as I suspected, we're getting lots of great questions in from the audience. Feel free to answer any of these, but also if one person is answered and you don't want to, just give me like a head shake and I won't ask you. So here's an interesting one. We're talking about going back to sort of data privacy. There is this is something I did not realize, and I'm going to go ahead and submit that. I will submit that this may be true. It sounds like it's probably true. Think about the conversation on data privacy. In a space where some companies actually go out of business, for instance, in this case, 23andMe, that data is now actually on the open bankruptcy market. Is there a concern of, if you have a company that has gone out of business and their data is now potentially out there for people to access, does that give you pause in the way in which you might engage with others with data that you've generated?
Yeah, great question. I definitely think it gives us pause. We always want to vet anyone who's going to partner with us, and I mentioned earlier the contractual obligations, data use agreements, all of those things, certifications, regulatory requirements. So we would definitely, anyone who's engaging in this kind of technology to deploy, you would want to vet them fully before you engage with them. That's one of the first things we ask, right? I mean, so what are the security certifications and what's your level of compliance, and those boxes have to be checked before moving forward with any engagement.
A potentially related question. So going beyond sort of the contact center claims and education, are there any use cases that are being developed for pre-auth, fraud, and risk, credentialing, and value-based care, and any challenges in scaling automation in these use cases?
We have use cases developed in all those three areas, but not together. So we have use cases in the fraud, waste, and abuse space, which is about monitoring DME fraud and a lot of different types of fraud, which are, the thing with frauds is that it's a very temporal phenomenon. Like this month, something is high with fraud, and the next month it will completely die down, and something else will be, showing a spike. So we have lots of different monitoring outlier detection algorithms as well in place for fraud, waste, and abuse detection. Then we have initiatives in process for value-based care. We are not very mature yet. What was the third one? Sorry.
Let's see. Pre-auth, fraud and risk, credentialing, and value-based care.
Yeah, so for the pre-auth, I've been, ever since I joined the organization, I've been asking this question to everybody, like, why do we have prior auths? And again, this is contentious. Can we just remove prior auth and from the front end and have in the back end, like AI make the decisions for what should be needing an authorization? And we haven't quite solved exactly that problem, but we have made a lot of progress through some other in some other areas. So for example, the claim adjudication piece that we have implemented, it's for approving claims that need medical necessity review. And we have been seeing a lot of success with that. Up to 47% more cases are adjudicated each day. So we are much faster because of that. We also have an appeals review process implemented as an AI model where we are able to overturn up to 60% of the appeals without almost in real time. So they don't even go through the approval queue. So it's a significant time savings, backlog reduction, all of that.
Stephen, Vikesh, anything else you want to talk about in terms of other use cases that are worth noting?
So a lot in the pipeline. Nothing is in a test or live environment yet, so probably defer to maybe next year.
Yeah, I would agree as far as those areas are concerned.
I'll just say, going back to the prior auth conversation, this is not about AI, but I will say employers are pretty defensive about the idea that we do need to engage in prior auth sometimes. I think they're inappropriate use cases, but reminder, we are spending $25,000 a year for healthcare right now, and that's with pretty aggressive prior auth. If we sort of take all the gloves off and we were like, sure, we'll just pay for whatever, the doc writes a script, we'll pay for it, and we won't sort of question it. We can see our costs continue to skyrocket even worse than they already have. So let's see, I've got a question here that kind of around the patient experience. So the question is, for engagements where AI is supporting patient diagnosis or journey, where is this information stored, and do patients have access? Maybe start with Vikesh, and then if you guys have anything else you want to add.
Yeah, so right now we're not using it to help clinicians with diagnoses. We're letting the clinician do that. I think that's going to be coming down the pike. From a patient experience standpoint, we're hearing from our facilities and our clinics that very few, if any, patients have said, no, please do not use AI in my care. They seem to be open to the fact that this is only going to help their care, augment it. And I'm speaking of 4 pilot sites in the emergency department, numerous clinics, and a couple of inpatient units. But so far, so good. Very good patient response feedback.
Yes, so we have a platform in place which helps patients understand their coverage, benefits, prescriptions, follow-ups, any kind of questions that they have around their care, in their care journey. And we also did an assessment or an analysis and figured that patients who registered in that platform and have an account and are using it actively are 50% more likely to follow through the preventive care procedures and recommendations. So it's a big cost savings.
Going back to the questions or the conversation around education, are there any sort of, we know that it takes a while and it often slows payment and it causes issues for providers in terms of actually getting paid and patients. Are there any steps in the kind of the current education framework that potentially are not needed anymore if a really effective AI engine was educating more accurately?
I think for the short term, it's going to be hard to skip over that. Like I said, we're relatively early in this journey, and for right now, we've got to be more comprehensive than not. Now, if we have this conversation in 5 or 10 years, yeah, I think there's some shortcuts we could take.
Steve, you talked about sort of you guys always make sure that at the end of the day, there's a human being looking at things. Do you feel like those human beings their workload has been lessened, so at least they're able to kind of review and process things more quickly than they were pre-use of AI?
Yeah, for sure. I mean, that's obviously the goal, right? To be able to do more with current staff, that kind of thing. Also, it applies on the development of these solutions, right? So as we begin to develop a model, let's say a machine learning model or an AI model, you're always going to have not only the technical folks, but also the clinicians or the clinical folks who are reviewing that information, validating that data, validating the machine's output, helping retrain those so that we're not just resting on, how the machine was trained maybe, months ago, that's constantly having to be revalidated. So there's the human interaction part on that side as well.
So here's a really interesting question, and one that I actually have a little bit of insight to, and then would love to hear from our panel. So how do you foresee AI-driven predictions for medical events influencing payers' strategies in funding preventative care, and what steps are being taken to align reimbursement models with some of those emergent technologies to enhance member experiences? So the little sort of nugget that I have is we spend a lot of work at the National Alliance and with our coalitions on helping them deal with high-cost claims, right? 2-3% of people in the commercial world drive 30 to 70% of the overall cost for an employer. Not a huge surprise, not necessarily even a bad thing. You get cancer, it's going to be really expensive. You get by bus, it's going to be really expensive. But if there are things we can do to deal with some of those high-cost claims, obviously we want to do it. And one of the things we've started to see is employers are working with their carrier sometimes, and particularly with AI-driven vendors, to say, we've looked across your entire patient population, and we've identified, the following 25 people that look highly likely that they are, maybe we know they're hypertensive or we know that they're whatever, and maybe if we could put some additional supports around those folks, we can actually keep them from having a heart attack. We can keep them from moving into the next stage of kidney disease, whatever it is. It's promising. I don't know that it's actually saved money yet, but it's certainly kind of the right idea of finding where your hotspots are and seeing what you can do about it in the front end. But would love to hear more about sort of how you guys envision or are currently using AI to sort of identify ways that are in more preventative space.
So early on in the journey, we're currently not using AI for preventive care at all, but I love your thoughts. I think we're headed in that direction. Thoughts from you?
Yeah, so I feel like AI has the potential to revolutionize a lot in the member experience preventive care space in the next 3-4 years. And I'm not saying the work will be done then, but a lot will be done by then. So what we are doing right now is we are building specific models for the top 5 comorbidities that drive most of the cost in the healthcare. So for example, for hypertension, we are trying to measure the likelihood of somebody getting, somebody with high risk. So quantifying the risk is one model, adherence is another model, compliance is another model. And then trying to piece them all together to infer cost. We cannot build a model about cost because that is going to be biased, right? So we don't do that ever. So we are trying to build specific models like that so that we can have targeted outreach to patients who can be who can benefit from preventive care before an unlikely event has happened. So that's our approach for the top 5 diseases. And once we are through, maybe we'll go down the list and see what more we can do.
Makes sense. So I appreciate it. We're sort of jumping around a lot because I'm getting lots of good questions on different strands of our conversation. But I want to go back to the question of sort of humans kind of in the loop versus full automation. You guys have sort of all identified that as of right now, you sort of always make sure there's a human who's involved. The question coming from one of our audience members is, for more basic and low-risk activities, it seems like the value prop kind of decreases with human involvement. I'd be interested to hear, is there a sort of a tipping point or a place where you might say, okay, the AI has developed far enough, the risk profile on this particular issue is low enough, we're going to basically provide full automation without any sort of human interaction. Is that in the foreseeable future, or is that not quite? We're not quite there, and we wouldn't exactly know what to look for when we get there.
So, what I think of when you ask that question, I think it's a really good question, is a lot of our physicians out there, they use human scribes to capture their documentation. And I'm sure the first 2, 3, 4 weeks when they had this scribe, they were reviewing all the notes very carefully. And then once they had that trust, it was more like a quick glance and a signature. In my humble opinion, I don't think we're anywhere close to getting rid of that quick glance. That human's always going to be there, at least short term. And then, like I said, 5, 10 years from now, maybe the conversation's a little bit different. But for right now, I think we just need that human.
In our experience, we have noticed that AI makes the best decision switch. So exactly to your point, right? Like, when can we have full automation versus when is it that the human is needed? So AI can decide that very well based on historical data. So to give you an example for overturning appeals, the appeals which can be based on historical data, the appeals which can be overturned with high probability, AI goes ahead and overturns it. The ones which cannot be is where the human comes in. So if we can reduce 60% of the queue by using AI for full automation, in a full automation configuration, that's a big savings too. And then for high-risk scenarios such as summarization as you pointed, right, you said that involving a lot of humans takes away from the value. I don't know if I necessarily agree with that because it depends on how we frame the evaluation in the first place, right? So when we are building like a clinical summarization tool, we are first doing model-based evaluations where we are asking for offline evaluation, where there is historical data that exists, and an AI generates a summary, and we can ask another AI. We can create another AI to ask we can ask another AI to tell us whether the answer given by the first AI is close in completeness and conciseness and in meaning to the answer that is existing in the ground truth. So the AI versus AI for the offline evaluation, and for the online evaluation, we will have an actual nurse practitioner in the loop who looks at the recommendation that is generated, can provide active feedback, which can then get integrated into the answer. And then we can do evaluations like this before we roll anything out. And again, I'm making it sound very simple. It's not as simple. We have to go through very thorough evaluations, but that's how we are approaching it, baby steps.
I think you brought up a really good point. You know, all three of us up here, or all four of us, I should say, are in different parts of the healthcare chain. And as long as something is not going to risk quality of care, patient safety, I think there's an avenue to rely on AI more. You know, for the examples that you gave, no patient is going to die if by some chance AI made a mistake. Yeah, will there be an appeals process, and could extra dollars possibly be spent? Yes, definitely. When we're using it, you know, if I'm using it in the hospital and the AI makes a mistake and a patient comes with a heart attack and the LLM says cut off left pinky toe, you know, we don't want a surgeon cutting off the left pinky toe. That could compromise health. I mean, I'm being a little facetious, but you understand what I'm saying.
Yeah, totally
Steve,
agree
anything
with
else to
you.
add?
The high risk, I'm talking about tackling more low risk, high impact problems. A lot of administrative efficiency problems end up being that. So
Yeah, I would agree. That's what I was going to say. That's my experience too. I think the short answer to the question is yes. I think there are some thresholds that could be met where you could go full automation, but it's the less complex cases and the smoother, easier, simpler processes. I guess I would put it that way. But yeah, I mean, I think you build some analysis, you have some metrics, you have some thresholds, and you determine, sort of draw the line on where you can fully automate versus having that human.
Thank you. So we have just a couple of minutes left. I have one question that came in that I think was sort of directed at a point that I made, and then I want to finish with kind of a couple of questions around sort of what you look for in the future. So the question for employers is, how do you ensure that there's no bias in the workplace when using AI to develop or to help protect employees at risk of serious and costly diseases? It's a really good question. I will say it's something that employers face all the time. When they're actually able to look through their claims data, it's not hard for the people in the benefits department to identify, not necessarily by name, but generally kind of who that person might be. That's part of the reason we have HIPAA, we have the Genetic Information Non-Discrimination Act. There are really strong firewalls which prohibit almost everybody, even in a benefits department, from seeing claims level data. There's only one or two people who can do it, and they have to be certified. And frankly, the penalties for discrimination against somebody because of their health status are so gigantic and so catastrophic for a lot of employers. Employers tend to be pretty good about saying, like, if I fired somebody because they had or were likely to have high cost claims, the cost of that could be in the tens of millions of dollars. So the last question that I just broadly would like to ask each of you to give maybe 30 seconds on is basically what do you look for? One of the questions was how do payers and providers cost justify AI investments? What are you looking for? What's the value? What's the cost savings, improved outcomes, et cetera? And would love to kind of hear just what are your recommendations for this group as they consider, as they're moving into the AI space, what they should be doing to attract potentially you guys as customers or partners.
So definitely get in this space. You got to keep up with the Joneses. It's where the industry is moving. Be responsible about it. Like Samta said, we also have a responsible AI committee that makes sure we're using AI responsibly, and expect that change management exercise. Not everybody's going to get it the first go around. You're going to have to work with the providers, the payers, whatever industry you're in, to make sure they understand it, they're on board, and are ready to move forward.
Yeah, I would just say make sure that your business and technology initiatives are aligned. Obviously, security is a big piece of it. Data governance, that you're sound in that area, and really build proof of concepts. We've all been talking about proof of concepts, and we're all doing them right now. But find some proof of concepts and don't pick the most complicated one right out of the gate, right? Pick something small and get some easy wins, and that'll give you some momentum to move forward.
Santa, any closing comment?
Yeah, so I think we have to get the data strategy right to get the AI strategy right. So sometimes not having data, quality data, access to quality data, or having data live in vendor silos do not help. So that is very important. Then another thing is when we are thinking about proof of concepts, right? We have to. I feel like we have to make sure that the proof of concept is right-sized. It's not too small. It's smallish, manageable, but it has a vision to be scaled or expanded to other areas seamlessly. And what I've realized from our experience is, if you launch one successful generative AI product, your credibility score goes very high as far as the business team's buy-in, leadership buy-in goes, and then you will be asked for more and more opportunities. So really focus on getting that first implementation right, because that creates trust, and we are changing behavior and changing culture for something that has never happened before. It takes time, and getting that first implementation right is very important.
I want to say thank you very much to our terrific panel. Thank you all for being here, and enjoy the rest of the conference.